So good afternoon. Thanks everyone for coming out. So I usually start out these. It seems like pelvic floor disorders are less clear to people and physicians even exactly what they are than like cardiovascular disease or diabetes. So I usually start a little bit about talking about an overview of what are actually pelvic floor disorders are. And I think if you're going to talk about something called pelvic floor disorders, I just want to remind everyone back to their basic anatomy, what's the pelvic floor? So the pelvic floor, if you see the pelvis here, the pelvic floor is this whole big bowl of muscles, sort of the levator ani muscular complex. And that's actually, if you think of, I usually use it for patients, if you think of the pelvis sort of like a bowl, the pelvic floor actually is sort of the bottom of the bowl. And that's on which your bladder, your uterus, your rectum, your vagina all rest. And so that's basically the primary support structure of all the organs in the pelvis. So what are pelvic floor disorders? Broadly speaking, they are disorders that accompany like the pelvic organs. So they're urinary control problems, urinary incontinence, urinary urgency or frequency, prolapse of the pelvic organs. People think about uterine prolapse, the vaginal prolapse, rectal prolapse, and similar to bowel control problems, we also take care of a lot of women with urinary control problems, bowel control problems like fecal incontinence, difficult defecation, those things. So everyone is also really well versed. We hear all sorts of great red ribbons and red suits for heart disease, and we hear so much about breast cancer. And so if you say 1 in 8 women has gets treated for breast cancer in her lifetime, 1 in 3 women in this country is going to have a pelvic floor disorder. So it's just not sexy. I mean, honestly, but think about it. 1 in 3 women, look around, there's a lot of women in the room. So every 3 of you look around, someone's going to have a problem with urinary control, a bowel control, or where their vagina is basically turning inside out. I mean, that's terrible. So we're going to have our own ribbon at some point. We just don't yet. And if you look at urinary control problems are probably the most common and get the most billing. That's partially because pharma has actually gotten really involved in treating urgency incontinence or overactive bladder. So we got lots of nice advertisements for urgency incontinence. But about 60% of women by the time they reach menopause will have some type of urinary incontinence. I think that the statistic that's less well recognized is that 1 in 3 women, or about 30% of women who are reproductive age, who have had 1 baby, will have stress incontinence, so leakage when they cough or they sneeze, which actually goes back to what Dr. Mendelsohn was saying, is that one of the first things that we find is even in young patients, postpartum that come in, they have to stop exercising. They can't run anymore. They can't jump on the trampoline with their 3 or 4-year-old. And probably for patients, even more alarming is that 1 in 5 women who has a urinary control problem, and you see how common those are, also has a bowel control problem. And if you actually talk to women who leak urinary incontinence every single day, and they leak bowel, have stool incontinence or fecal incontinence once a month, and you ask them what they want addressed first, it's actually the fecal incontinence. I mean, it is a devastating disorder. Similarly, 1 in 5 women who has a pelvic floor disorder, and these are studies of women that have made it to the healthcare system, so that doesn't include all the people that aren't insured and not getting healthcare with poor access. 1 in 5 women who has a pelvic floor disorder actually has surgery for a pelvic floor disorder. So before we kind of launch into who we are, I usually just like to kind of start out with some of the myths that I commonly hear from both patients and clinicians alike, which actually I'm happy to say that as we go through the course of this talk, you'll see some of these are no longer true. First one that actually probably drew me into the field is that it's normal to lose control of your bladder or your bowel with aging. When I actually decided to become a urogynecologist in medical school. I decided I wanted to operate, trying to figure out what's the best place. Happened to hear urogynecology, it was surgical gynecology, so I said, I'll give that a shot. And one of the very first women that we saw was 63. That seemed really ancient at the time. Not so much anymore. And she was rollerblading big avid rollerblader. I was a big avid rollerblader too. Once I had to start making a living with my hands, I stopped. And she had actually stopped rollerblading with her grandchildren because she was so incontinent and her primary obstetrician gynecologist, who had delivered her 3 children, 30 years ago, was like, oh yeah, I mean, that's normal. That's what happens to women when they get older. And the woman who went on to become my mentor and senior partner for many, many years leaned over, put her hand on her leg and said, it's certainly common for women to have bladder control problems as they get old, but it's not normal, and we can help you. Another big myth is that surgery is the only option, or that surgery doesn't work. 10 years ago, the level of randomized controlled trial, or level 1 evidence for comparative effectiveness for different types of surgical treatments for incontinence and prolapse was pretty much non-existent. And I'm happy to say that the federal government has put much more money, not nearly as much as they should, when you think about 1 in 3 women have this disorder, into funding comparative effectiveness research. So we actually have good comparative effectiveness data showing both anatomic and subjective success rates. And the surgery does work. The flip side of that is there are many pelvic floor disorders that we can't even treat surgically. They're only treated with non-surgical options. Another big one that patients come in is I put off having this because people told me I couldn't lift anything heavier than 10 pounds for 3 months, and I couldn't do any high impact activities. I'm happy to say that that's probably not true, and that the urine is sterile. How many people think the urine is sterile? Like normal asymptomatic people? Yeah, it turns out it's not. It has a microbiome just like everything else. So we'll get more on that. So as I talk a little bit about the integrated pelvic health program, I want to kind of make a distinction between interdisciplinary, multidisciplinary, and transdisciplinary. I think a lot of people talk about interdisciplinary and multidisciplinary research. And if you actually look at the definitions of interdisciplinary, it's clinicians and researchers from multiple fields who interact with the goal of transferring knowledge. So that's good, but people are just sort of acting in parallel, talking. Multidisciplinary, which is I think the first step in becoming transdisciplinary, is where clinicians and researchers from multiple fields work together, but they sort of have separate conclusions, separate questions that they're answering. So the colorectal surgeons are going to treat fecal incontinence one way, and they're going to publish it in the diseases of colon and rectum, and the urogynecologists are going to treat it another way and publish it in obstetrics and gynecology or the Journal of Female Pelvic Medicine or reconstructive surgery. Probably still not optimal healthcare for women. So what we're really trying to establish is a transdisciplinary program in which collaboration, in which exchanging information, altering discipline-specific approaches, sharing resources, and integrating disciplines to achieve a common goal. So as you'll see when I talk a little bit about the integrated pelvic health program, we really try to encompass this transdisciplinary approach where we're trying to mold each other into a better healthcare outcome for women instead of each kind of practicing in silos. So who treats our pelvic floor disorders? Again, it's got to be a transdisciplinary group of people. I think this is why urogynecology came into being. If you think about how tight that pelvis is, and you have a bladder and a vagina and a uterus and large bowel and small bowel and muscles, and if you try to separate those things out, which is what we did for very many years, you get a lot of, they're having their bladder taken care of by the urologist, and then turns out their vagina's hanging out, so they have to have a second surgery. And probably you can't treat one of those organs without also treating the other ones. So here at Northwestern, they established the Integrated Pelvic Health Program, which has specialists always working together, not in siloed, but in an integrated or transdisciplinary way, from female pelvic medicine or reconstructive surgery, from colon and rectal surgery, and physical therapy. So a little bit about female pelvic medicine or reconstructive surgery, or I often refer to it as urogynecology. This sort of came up out of nobody was really taking care of the female pelvis. The gynecologists were just sort of dabbling in urinary incontinence. The urologists were dabbling in prolapse, and those two disorders are very commonly go together. So dating back to about 1996, this was actually the year that I started residency, right? Yeah. And so I knew I was going to be a urogynecologist. The American Boards of OBGYN and Urology came together, recognized the need for subspecialty training encompassing both disciplines, and started accrediting fellowship programs that you can get to from either a urology background or a gynecology background. It also meant that the fellowship went from 2 years to 3 years, so it was a memorable year for me because I realized I was going to be adding a year on to my training that I hadn't planned on. And then in 2011, the American Board of Medical Specialties officially recognized female pelvic medicine and reconstructive surgery as a specialty. And then over the next 2 years, and what happens is when the ABMS recognizes you as a specialty, that's when you can actually move forward, creating a certification exam and start certifying the first individuals. So in June of 2013, the first individuals kind of took the test for subspecialty certification in FPMRS. And in that first group of people nationally to actually achieve subspecialty certification were 4 of the physicians here at Northwestern Medicine who practice in the Integrated Pelvic Health Program. So a little bit about our team. There are 3 board-certified urogynecologists that work with gynecology backgrounds that work in the IPHP. One of whom is Maggie Mueller, who's the newest addition to our team, who's actually going to be leading the incontinence workshop. The other is Christina Lewicki-Gaup. And then we have 2 urologists. Their pictures were there. I'm not sure why they're not showing up. Dr. John Harrison and Stephanie Kielb, who also both have taken the certification exam and practice with us. In addition, within our space, we also have 2 colon and rectal surgeons, Dr. Amy Halverson and Dr. Anne Marie Bowler. These people have primary certification in general surgery as well as subspecialty certification in colon and rectal surgery. As many of you probably know, most colon and rectal surgeons are kind of interested in cancer. It's a little bit sexier, breast cancer sexier, colon and rectal cancer sexier than incontinence. The really lucky thing about our team is Anne Marie Bowler is actually a colon and rectal surgeon who would prefer to take care of women with fecal incontinence or rectal prolapse and pelvic floor disorders than she would to do cancer, which is a really lucky thing to have. Having practiced at other institutions, sometimes it's hard to engage colorectal and pelvic floor issues. We have 2 different groups of physical therapists that work with us. Karen Weeks is a newer PT that we just hired who actually works for Northwestern Medicine and is full-time part of our team, designing research protocols, taking care of patients, and then a private physical therapy group, Cotorinos Physical Therapy, actually also leases spaces. So in addition to the colorectal surgeons, the urogynecologists that are always practicing in the IPHP, there's 2 full-time physical therapy rooms running at all time, only doing pelvic floor care. So I also am a believer that probably to really advance a field forward, you can't just be optimizing clinical care, you have to be challenging paradigms. So I'm going to talk a little bit about our transdisciplinary research program, which all comes back again to pelvic floor disorders. And so everything we do takes other disciplines of medicine and focuses back on the female pelvic floor. Our big bins are we like to do comparative effectiveness trials and clinical outcomes research. That's probably the thing that I've been most involved in my career. I've been involved in many large multi-center federally funded NIH studies doing comparative effectiveness surgical trials. I was the PI on a multi-center grant where we compared straight stick randomized women in the operating room on the day of surgery to straight stick laparoscopy or robotic surgery. Found what most of the studies show, that you can do it a little bit faster and a little bit cheaper if you use straight stick rather than robotics. A newer aspect of our program is a translational program, which is really being headed up by Dr. Mueller, where we're actually looking at the microbiome. There's increasing data to show that if you just take urines from all women, most women have bacteria in the urine. We think it's probably protective. It's probably a good thing. There's probably the good guys and the bad guys, and when they get out of whack, the uropathogens like E. coli kind of raise up. There's even some newer data to suggest that certain treatment responses to urgency incontinence or overactive bladder medicines differ by the patient's microbiome. So if you have a certain microbiome, you may not have as good an outcome with your overactive bladder treatments. And then maternal childbirth outcomes, which I'll talk to a little bit on the next slide. One of my associates is developed a phenomenal research program, really trying to understand how we can improve care for young women with pelvic floor disorders. So this is Dr. Lewicki Gaup up here, who came out of the University of Michigan, was trying to get a research program going and realized that with 13,000 deliveries and high rates of forceps, there's a whole bunch of women at Northwestern medicine who actually have pretty severe obstetric anal sphincter lacerations, got grant funding to follow those women prospectively, and found out, amongst other things, that maternal outcomes were worse after forceps delivery. We can't really tell the obstetricians to stop using forceps. We try. So we have to figure out how can we improve care for women despite the forceps. And here's two trials that are going on. One is women who have had an obstetric anal sphincter injury. There's good data in the orthopedic literature that if you take a nerve and a muscle that's been injured and you hit it with some electrical stimulation, you can actually improve neuromuscular recovery. So right now we're getting ready to randomize women who've had an obstetric anal sphincter laceration to a transvaginal e-stim device or a sham device and look at pelvic floor outcomes. And probably most importantly, we're trying to get on the prevention bandwagon and we've designed a study to try to figure out if we educate women and put them through a rigorous training program, will they be more likely to weather labor and delivery without adverse outcomes. A couple of the comparative effectiveness trials we're doing, where we literally randomize women either in the operating room on the day of surgery or beforehand, trying to understand if we really have to put all these lifestyle restrictions on women, or if we should just let them go back to doing their thing, which is what we generally do. And then novel ways to treat mixed incontinence when patients have a little bit of urinary stress incontinence and overactive bladder incontinence. I think the microbiome work that Dr. Mueller's heading is some of the most exciting things that we have going on right now. This is a study that we just published where we looked at women who had urgency, frequency, and some bladder pain, and we age matched them to controls and did urinary microbiome, so looked at the bacterial DNA in both of those two populations of women. And there's more microbial diversity and a higher proportion of women who have lactobacillus as a predominant organism in normal women compared to women who have bad bladder symptoms like urgency and frequency. There's a couple ongoing studies where we're trying to, again, predict treatment responses with respect to the urinary microbiome. We're also involved in some large multi-center federally funded work where we're really trying to just understand and phenotype women with urinary incontinence, better get a grip on different phenotypes, different genetic phenotypes, microbiome phenotypes, symptomatic phenotypes, that we may be able to better direct people to one treatment or the other. So just in summary, our program is really a national model of transdisciplinary healthcare for the pelvic floor, encompassing urogynecology, urology, colon and rectal surgery, and physical therapy. So thanks, and I think we'll have time for questions during the